Yes.
Hello. Dr. Madu, can I confirm that you are here?
Yes, I'm here. Good morning.
Okay, awesome. Thank you. Great. Well, let's begin. Hello, everyone, and welcome again to the 2021 World Pre-Health Conference. My name is Andrew, and I'm immensely honored to present our opening keynote speaker, Dr. Ernest Madu. Before we begin, we wanted to mention that we encourage you to submit questions at any point throughout the keynote, and they will be answered during the Q&A session. Dr. Ernest Madu is an internationally recognized authority on cardiovascular medicine and innovative healthcare solutions. He is a leading expert in leveraging technology to bring the access gap in quality healthcare delivery, and has used his expertise in leading innovative and transformative healthcare projects in Africa and the Caribbean. He also holds the academic rank of Professor of Cardiovascular Medicine and Imaging Technology, and is respected globally for his contributions to cardiovascular medicine and health systems innovation. Dr. Madu has published more than 100 scientific papers in peer-reviewed medical journals, and his work has been profiled in leading journals and magazines. He is a fellow of the American College of Cardiology, the European Society of Cardiology, and the Royal College of Physicians, Edinburgh, and was recently awarded the fellowship of the International Academy of Cardiovascular Sciences. Professor Madu is the managing partner of IHS Group, Nashville, USA, and also serves as chairman and CEO of the Heart Institute of the Caribbean in Jamaica. You can read Dr. Madu's full biography in our handbook, but in the meantime, please join me in welcoming our first keynote speaker, Dr. Ernest Madu. Dr. Madu, feel free to...
Good morning, Andrew. It's a pleasure to be here. The host, I believe, has muted my video, so if you can unmute. All
right, that is.
Am I unmuted now? No, my video is still muted.
Okay.
If the host can please unmute, it will be under Monday in my car. Yeah.
Okay. Does it work now?
Is it? No, not yet. Okay, fantastic. Technology is good when it works. Yeah, thank you, Andrew, and thanks to you and your team of organizers. It's been a pleasure to be here with you, and thank you for inviting me to this very important meeting. I'm going to be speaking today about other factors that we often neglect when we talk about healthcare delivery and healthcare access. And I've been asked to speak about social determinants of health from a global perspective. Let me try to share my slide so we can. Okay. All right. Can you see my slide? I think it goes to the end of it. All right. Andrew, can you see my slides?
Yes. Yes, I can see it.
Okay, so let me go to presentation. Okay, thanks again for the invitation. In the interest of time, we will move forward with this meeting. Hopefully at the end of the discussion, we should be redirected in some ways into what healthcare really means and what it takes to put the structures in place to deliver good quality healthcare to all, because as we have seen from the COVID pandemic, it's not beneficial to any nation in the world to be the only place where access to good healthcare could be obtained, because illnesses have no geographical limitation. They will travel across borders. WHO defines health as a state of physical, psychological, and spiritual well-being, not merely the absence of disease. This means that health outcomes are impacted by a complex interaction of many variables. The variables I want to focus on today are the social, cultural, economic, and geographical imperatives that affect healthcare that we receive. Who lives and who dies often is determined by a host of factors that hopefully we can address if we pay attention to them. Science has been making tremendous leaps in the past 25 to 50 years. There have been significant advances in the way diseases are detected and managed. We now have new and more effective treatment options for diseases that were previously thought to be untreatable. Better and safer drugs with less adverse events have been produced. We have customized drugs to individual genetic profiles. Now we have a burgeoning field of personalized medicine. We now know that we can screen and detect diseases very early. These very advanced techniques are available. They're more accurate, and now we can make surgical techniques that are better and the outcomes are improved. Overall, the quality of healthcare has improved around the world in the past 25 years, and they have been done in a way to make it more universally accessible to people. We have now also, with the COVID pandemic, we can also see that better, safer vaccines are more readily available. Whether they're universally affordable is still debatable. But despite these advances in science, there are a lot of gaps that remain unfilled. There will still be more than 5 million deaths every year in children under the age of 5. These deaths are occurring mainly due to socioeconomic disadvantages, and they're happening in the most impoverished countries around the world. They're also happening in rich countries within the most vulnerable and marginalized communities. By 2025, it's been estimated that life expectancy at birth in at least 26 countries will be more than 80 years, and yet less than 55 years in many other countries. That's a large gap. If you look at disease-adjusted life expectancy, which is a term coined from the Global Disease Burden Project, looking at how the measure of quality of life in the presence of illness for individuals, you see disease-adjusted life expectancy, otherwise called DALE, is lowest in the poorer countries of the world, euphemistically called developing countries. So these global inequalities and inequities persist. And the question to the global community is, why are these medical and scientific advances not being applied to address health inequalities and bridge the gap in access for all citizens within nations and across nations? And we are going to now explore why this is the case, and hopefully you young ones coming into the field will ultimately provide answers. Michael Marmot, in a landmark study in Lancet in 2018, gave us a very good definition of social determinants of health. These WHO has defined social determinants of health as the circumstances in which people are born, grow, live, work, age, and the systems put in place to deal with illnesses. This is a very simple definition on its face, but if you dissect it, it encompasses a complex set of interactions between social, cultural, economic, and environmental factors that result in health inequities. Because of these social determinants of health, we have a spread of life expectancy of up to 48 years between countries, and the life expectancy as wide as 20 years within countries that can be attributed to gross inequalities in healthcare. These social determinants are relevant for both communicable and non-communicable diseases. These are also avoidable because they arise from circumstances in which people grow, live, work, and age, and the systems put in place to deal with illness. Go back to the initial definition by the World Health Organization of what health really is. So if we understand that these circumstances arise because of the circumstances in which we grow, live, work, and age, and the systems put in place to deal with illnesses, then it means that we have the capacity to change them. These conditions are shaped by political, cultural, social, and economic forces. Sometimes these forces are overwhelming and unsolvable for the individuals at the lowest strata of society, but the society at large can make a commitment to addressing these issues by addressing the social and economic policies that affect the lives that people live, and also the political and governance structures that are put in place, to either give people a flourishing life or a blighted life. Let's talk about some of the observations that have, given us an insight into why this problem is so. Vilfredo Pareto was an Italian social economist and political scientist. In 1906, he made a very important observation that 80% of the wealth, including land in Italy, were owned by 20% of the population. And 20% of the wealth is distributed among the bottom 80%. This societal inequality has become recognized as the Pareto Principle. And there is the Pareto Index that further describes this. This inequality exists till today. If you look at, and we call it also the 80-20 rule, you can take the global GDP and relate it to the Pareto Principle today. The richest 20% of the population control about 83% of the global income. The poorest 20% control only 1.4%. And if you look at the top 40%, then you have about 95% of global GDP in the hands of the top 40%, with only 5% of global GDP in the hands of the bottom 60%. This is very inequitable distribution of wealth, and it affects the way we live, the way we grow, the way we die. Healthcare access and utilization appear to follow the same Pareto Principle, with 20% of the population utilizing 80% of global healthcare resources. How much richer are these richer countries compared to the poorest countries? If you look at income inequality by country, you will see a gap that is very disturbing because in the richest countries of the world, the richest 20% of the people the richest 20% of the people are at least almost 7 to 10 times wealthier than the poorest 20%. And that is also an imperative that drives access and utilization in healthcare. These discrepancies and inequalities are driven essentially by social determinants of health. And you have to look at it broadly into looking at the living and working conditions, the work environment, the educational attainment, access to food, unemployment, water and sanitation, healthcare services, housing, individual life factors, social and economic and community networks. All of these tie into a network that create either an advantage or disadvantage in access to good quality healthcare. The same Pareto's principle shows us that the greatest burden of disease is found in low-income countries and poorer communities within even the rich countries. 80% of global disease burden is seen in the poorest 20% of the countries and also in the poorest 20% of neighborhoods, even within the rich countries. Yet 80% of global healthcare resources are in the richest 20% of the countries and in the richest 20% of the population within countries. What this means is that usually those with lower income have less access to healthcare services and utilization. And that has a big impact in the way people live and then the way people die. There is a difference between health inequalities and health inequities. Health inequalities measure differences in the health status of individuals or groups. This could be due to genetic, social, or demographic factors. Health inequities, on the other hand, also known as health disparities, represent a subset of health inequalities that denote an unjust difference in health status between groups or between countries. These could also be avoided by reasonable means, but there are promoters of health inequities that we must recognize if we are able to deal with the consequences of health inequities. These will include socioeconomic and cultural exclusion, which we can address, poor governance, which is a political process that countries have to address, and then corruption within the systems, between countries and within countries. These are things that tie together to create socioeconomic and cultural exclusion and exacerbate health inequity. This is an illustrative slide. On the top of the slide, you're going to see the barest minimum that is being applied to address a patient with a fracture that needed surgical attention. Then on the bottom part of the slide, you will see the enormous resources that are available. You don't need to be a magician to figure out which one is which. The top of the slide represents the poorest marginalized communities in the lowest income country, and then the bottom represents the richest 20% that we talk about. So we cannot address these socioeconomic determinants without paying attention to the issues that drive them. I will focus on two very critical issues, which will be education and poverty, that will drive these processes. Education and income are markers of socioeconomic position. People with lower socioeconomic position are more likely to have worse access to healthcare. But social position also influences whether a person is exposed to health risks or has resources to buffer health risks. If you go back to the Global Burden of Disease project that I mentioned earlier, it shows that the major healthcare problems around the world are actually quite similar. The difference is in the resources to deal with these problems. If you look at about 169 to 170 countries, you'll see the same pattern of illnesses in one form or another. Then if you look at the so-called developing countries, you'll see a pattern that's also developing, which we've called the epidemiologic transition, where these countries are transitioning from communicable diseases to non-communicable diseases, but still do not have the resources to deal with either. If you look at non-communicable diseases, you'll have about 58 million deaths every year in the world, and nearly 70% of those occur in the poorest countries of the world. but you look at the resources available to deal with these illnesses, about 80% of those resources are in the most developed countries of the world. So that's an imbalance in demand and supply. So the places where the demand is most have the least supply of resources, because we're now talking about the capacity to deal with these illnesses, whether it's a capacity in terms of infrastructure or capacity in terms of human capital, does not exist. And we will illustrate that a little bit, more as we go forward. But let's focus a bit on education and why education matters. Educational attainment increases health knowledge and literacy and improves behavior. Even nutritional choices, avoidance of drugs and alcohol, exercise, all of those things have impact on health, but you have to be educated enough to understand how that relates to your health. Educational attainment also improves your ability to secure good jobs and have better working conditions. And in most countries, that also will mean that you have access to health insurance and have access to retirement benefits and sick leave, so you can deal with illnesses when they arise. This also means you will likely work in a place that limits your exposure to hazardous substances, and then you have better control of your working environment. Educational attainment also gives you a sense of control. You have a choice to pick and choose which kind of jobs you take. You're no longer working out of desperation, and then you can avoid, the jobs that are more likely to put you at risk. So education is a strong predictor of long-term health and quality of life. It's also a strong predictor of your ability to earn decent income and achieve an appropriate social status that will give you an advantage. Almost everybody in this lecture today will fall into that bracket, whereby your education and your educational attainment, you will achieve a social status that will give you access that 80% of the world will not have. The greater the gap between the richest and the poorest people, or the educated and the uneducated people, the greater the difference in health and healthcare services access and utilization. We also have this study from Michael Marmot, which shows us clearly why education matters. And if we're going to solve this problem, then we must push to get the greater population of the world educated. Those with no education have the highest mortality rate, and those with some education have less mortality rate. So as your level of education increases as a group, the mortality rate drops. Poverty is a vicious cycle that makes poor health almost inevitable, because one, low education leads to low job attainment, poor job payments, poor income, and it's a vicious cycle that denies you access to good healthcare. So if we're looking at primary determinants of health, we must look at education and poverty. Low socioeconomic status alone is one of the strongest predictors of poor health and development, and is associated with material deprivation resulting in limited access. And there are also, neuroendocrine responses to stress that low socioeconomic stress imposes on individual psychosocial well-being. The poor people suffer disproportionately from disease. If we look at several parameters, this slide shows tuberculosis death in a population. You'll see that, whether it's TB, HIV, AIDS, maternal deaths, under 5 deaths, underweight, the richest 25% compared to the poorest 25% is a wide gap in affectation. GDP per capita and life expectancy is also well demonstrated. Among 169 countries reporting, you'll see that GDP relates to outcomes in healthcare. If you look at the richest countries, you'll see that there has been significant increase in life expectancy between 1975 and 2005. In the poorest countries, life expectancy has not moved. Poorer people live shorter lives and more often ill than the rich. But health inequities harm everyone. It's not just, some slogan. If you look at the study by the Navy and co, you'll find that well-being declines as income inequality increases. The general well-being of the population is lowest in the countries with the highest income inequality. If you look at child well-being, it's also lowest in the countries that are more unequal. United States happens to be one of those. If you look at the USA, Portugal, UK, child well-being is much lower than it is in Japan, Finland, Sweden, and Norway. And this parallels the unequal distribution in income that drives health inequity in a way that it harms everyone. Trust issues exist in countries where health inequities exist. People in more unequal countries trust each other less. Again, USA and Portugal are leaders in there. Sweden, Norway, Denmark, and Finland, and Japan, there is more trust between individuals because there is a more equal society. Prison populations, not something to be proud of. In the most unequal societies, prison populations are highest. Again, Singapore, United States, Portugal lead the pack, followed by Israel and United Kingdom. And then you go to Sweden, Finland, Norway, Japan, Denmark, the same countries, prison populations are much lower. And that is, again, how health inequities harm everyone. So we will now talk a little bit about COVID and how that has impacted the world with respect to social determinants of health. So there is disproportionate impact on lower socioeconomic groups. The outbreak has been devastating in countries with lack of access to clean water, overcrowding, lack of access to green space, underlying health conditions, and in communities that are poorer because they work in jobs that often are customer-facing jobs. In the United States, for example, there's been a lot of concern about the Indian and Native American communities where there's been lack of access to clean water, live in a crowded environment, and people have multiple underlying conditions. And then if you look at communities within the United States working customer-facing jobs, they have been the ones that have been most affected. And then you look at populations, marginalized communities, Black people in the United States are 3 times more likely to catch COVID and 2 times more likely to die from COVID. And the same pattern exists in the United Kingdom. And that also mirrors income distribution and access to healthcare resources. COVID vaccine inequality is a real thing. This has been an issue that should be of a concern to everyone because despite efforts that I will talk about with the COVAX initiative, vaccine access has again been a blight on the global community. Vaccine doses per 100 people in countries with highest total vaccinations. You're looking at Israel, UK, United States. That is where people have more access. President Biden committed to 100 million vaccinations in 100 days. He's achieved that in 58 days. But many countries around the world, especially in the poorest countries, still do not have access to vaccines. And there are a lot of issues. There's the Pfizer vaccine and the Moderna vaccine that requires more cold chain storage. And it goes back to the political and economic forces within these countries that have not created the environment for them to be able to store and manage distribution of such vaccines. And what it means is that they are relegated to other vaccines that will have better means of storage. And incidentally, some of those vaccines are also less efficacious than the Pfizer and Moderna vaccine. For example, that creates another health inequality and health inequity. But what are the solutions? It has to be targeted, multi-sectoral, and the public-private sector partnership will exist. Recognizing that we continue to have worsening indices of health status in many countries and among poor people, despite scientific advances, then we have to have a fresh look, improve conditions of daily living, improve socioeconomic structure and wealth distribution, and educational system to improve human capacity. But the health systems must be reorganized as well. We need to recognize smart and innovative application of technology in dealing with this crisis, but this is beyond the scope of this talk. These critical factors are essential in bridging the gap in health equity. Education and technology must form the backbone of how we address these problems. We must enhance global cooperation to improve access to healthcare for all. Without global cooperation, the world will never have health equity, and health inequality will continue to persist. The global cooperation that we speak about is demonstrated by the COVAX initiative. COVAX initiative is a multinational corporation founded to ensure that 2 billion doses of the COVID vaccines are made available to low-income countries by the end of 2021. That has been a very good imperative, but has not been as successful as one will hope. But we're in the early days, and we hope that it will get better. But still, it's a good example of global cooperation for action against the social determinants of health. In concluding, the take home for us is that social determinants of health indicate a complex socioeconomic set of factors that influence health status of communities. Health inequities harm everyone. Global health inequality is real. It worsens health outcomes for the world as diseases do not respect boundaries, as we've seen with the COVID pandemic that started in China and has shut down the rest of the world. And we've gone into a series of surges in multiple countries, and the economic systems have been devastated. Unemployment rates are rising. Health inequality is expanding. Health inequity is expanding, all because we failed to contain a virus at source. Now, the only way you can do that is we have to put resources towards a global intervention. I'm afraid that we're probably making the same mistake again, because as the richest countries of the world struggle to hog up all the vaccines to vaccinate their populations, there has not been as much attention to the poorer countries of the world. If we do not do that, the warning is real that you can vaccinate all of your country, but you cannot eradicate the pandemic, because you will have reintroduction of different variants of the virus from those countries that you have neglected to assist in getting access to vaccine. So solutions to these problems of inequities and inequality need a multi-pronged, multinational approach, but no one around the world should be excluded, and no one within countries should be excluded. The rich and the poor deserve to have access to good healthcare. No one should be condemned to a life of poverty, a life of poor health, just because of the accident of their birth or the accident of their social, cultural, or economic outcome. All right, thank you.
Thank you so much for that very insightful talk, Dr. Madu. Yeah, it was really interesting to hear about global health and your views on that. We actually have several questions coming in the Q&A, so I will moderate those questions. So first we have a question from Megna. How can individuals who are non-government officials endorse or propose certain acts or legislations in other nations that would promote higher education opportunities or would generally help reduce the socioeconomic health disparities that are especially detrimental for those in poverty.
Can you read the question again, please?
Yes, of course. So I think what Magna means is how can individuals not involved in the government directly help promote higher education opportunities or otherwise reduce health disparities in other nations?
Yeah, that's a very interesting question. It's so my response is that you have to lend your voice wherever you find you center yourself. You cannot wait until you are in quote unquote the high level authority, to effect a change. So most of the people attending this meeting, as a pre-health meeting, they're young people, they're, aspiring for careers in various aspects of healthcare. You can begin to think about these issues. You can begin to speak about these issues within your peer group, right? So you plant a seed, you don't know when and how it will grow. So do not wait until you have, quote unquote, the authority to speak. You have the authority to speak. You have your voice. Use it.
Thank you. And yeah, we have definitely seen this sort of activism becoming more and more prevalent during the pandemic, where we sometimes cannot rely on officials to make the hard decisions for us. And we have another question from Kevin. Do you see the medical field trending towards reducing health disparities? If so, what practical strategies have been helpful? If not, what do you think are the factors preventing this?
Yeah, another excellent question. Yes, efforts are being made, and this conference is illustrative of the efforts being made. The fact that the organizers recognize that this is an important topic, to bring into the discussion. That is part of the effort. Many years ago, social determinants of health were not even spoken about, right? So at least now we're speaking about it. Efforts are being made. Many academic centers are beginning to embrace the concept of global health beyond looking at infectious diseases, because previously global health departments in many academic institutions were just, travel clinics. But that's not what global health is about. Global health is about building the infrastructure to solve health inequality and health inequity. It's about looking at education and poverty issues that drive health inequality and health inequity. It is about training people to understand that every aspect of illness is affected by a complex set of social, cultural, and economic factors. So efforts are being made within major universities and major health centers around the world. It's yet not enough because we need more voices to speak about these issues. There's still some apathy because of lack of understanding. There is still a lot of implicit bias that drives the way we do things. And there is still a lot of underrepresentation in healthcare leadership, right? So healthcare leadership in certain important academic centers is still restricted to a very tiny subset of the population who do not have the lived experience of the larger population. So until we expand access, one of the things I did when I was on faculty at Vanderbilt was to assist the university in broadening its reach to increase enrollment of Black cardiology fellows into the program. Because until you have a diverse workforce, it is very easy to not recognize the things that are important to the larger population. So these efforts will continue to be made, and I encourage all of you as you move forward in your career to embrace this concept that a multicultural, a diverse workforce, will be beneficial to everyone. That is how you bring so many voices on the table and solve problems that are important to the greater population.
Thank you. So I think those questions sort of address the point of view of like more developed countries looking at global health. What do you think should be the role of developing countries who are experiencing these global health disparities in sort of trying to rise up out of those challenges?
Yeah, so the most important thing for developing countries is to cure the structural friction points that limit access to, good quality healthcare, right? So let me try to address a few of those. One is human capital, right? So what you have in the developing countries, most developing countries have become a net exporter of human capital to the most developed countries of the world. Their best brains leave. If your best brains leave, then you don't have the capacity to solve your problems because you're sending your best talents elsewhere. But it's a vicious cycle. Why do you lose your best brains? You lose your best brains because of structural deficits and infrastructural deficits that do not give them hope, does not give them the ability to build a career within your borders. So they pursue opportunities elsewhere, right? Why do you not have those structural, why are you not able to solve those structural friction points? Oftentimes it's because of poor governance, right? So I'll give you an example that is unrelated. I watched a video recently from the president of Ghana speaking to a group of, include the prime minister of Switzerland or somewhere. Ghana for many years, for over a century, have been shipping out their cocoa to Switzerland and elsewhere, and they make chocolates, and then Ghana buy. So they don't have it, so they have the input, but do not gain from the output. So Ghana is now turning inwards to begin to manufacture the chocolate, not sending their raw material. As long as the developing or the poorer countries are seen as raw material reservoirs of the world to supply the needs of the Western world, development will never come. So the way to solve this is that the better brains, the talents within developing countries have to be retained to build the infrastructure, the political systems, the governance structures to develop the society. You have to improve the economic well-being of the people to drive structural progress, and that requires talent. And so it's a complex set of factors. And let me also say that it's in the interest of the global community to encourage the less developed societies to invest in their infrastructure and grow the society. When they do so, all the world gains. China 30 years ago was considered a poor country, but China is now a global superpower. How did they do it? Manufacturing base, talents return to China. India, the same thing is happening. You have specialized hospitals all over India. These specialized hospitals are Indian nationals that gained knowledge elsewhere and were able to return to India.
Thank you. How do you believe we will be able to eliminate the colonial structures that continue to exacerbate health inequity in the global South?
Yeah, that is a very tough question because there are vested interests that are determined not to eliminate those colonial structures because those colonial structures serve the interests of the colonial master. So there is no interest in eliminating those. So it has to come from the collective will of the global community, to address those, problems. That's a very structural problem. For those who are paying attention to that, there is also the concept of colonial tax being imposed by France on former French colonies, and forcing those countries to hold their foreign reserve in the French National Bank. That is, a big problem. And as long as you don't have control of your resources, as long as you don't have access to your resources, you will remain impoverished. But it's very short-sighted, right? Because France is imposing colonial tax on French colonies and driving deprivation and poverty in those colonies. Well, what is happening is that citizens of those colonies are constantly migrating to France, and yet France is struggling to curb immigration into France. You can't have it both ways. It is impossible. If you don't allow societies to develop, you're shooting yourself in the foot. The same thing is happening in the United States. The last president was intent on building a border wall to stop the Mexicans from coming, right? You can't stop the Mexicans from coming. Most of us move to places where we find opportunity. The only way you can make people stay in a place is if you assist them to develop their places so that they have opportunity. If you don't have opportunity, if you live in Boston and the economic climate in Boston is bad, you start looking for a job in New York. You move to New York. New York cannot solve that problem by building a wall. So you cannot, we have a global community that have destroyed all walls, in the same vein that you're telling countries do not cut down their trees so you don't deplete the ozone layer, because you need, to safeguard the world from climate warming. Well, if they don't cut their trees, they cannot have industrial development, but you already have your industrial development, then you have to assist them in other ways so that they can create income. But you cannot have a two-tier system or a three-tier system where a major part of the world is considered as a raw material reservoir to feed the lives of the more affluent countries. That is very short-sighted. It will not help the world. It will not help the global community until we look at these problems in a globalized way to say that what is good one place is good in the other place. And every society will be able to build the infrastructure that helps the global community as a whole.
Thank you very much. All right, I think we have time for maybe a couple more questions. One from Michaela. Are initiatives used to address health inequalities sufficient to also address health inequities? Do these two distinct endpoints require different approaches?
Can you repeat the question again, please?
Yeah. Are initiatives used to address health inequalities also sufficient to address health inequities?
Yeah, okay. Yes and no. You have to deal with both because they imply slightly different things. Health inequities, deal with structures that we can control. There are health inequalities that we may not necessarily be able to control, but if we address the fundamental structures, then we can influence and affect both.
Okay, thank you. And maybe now pivoting more to the effects of COVID, what do you think are, what maybe diseases in the past or other sort of challenges that the world has faced in global health can inform our current efforts towards managing COVID-19?
Okay, an excellent question. So we can go back in time, from the hundreds of years from the bubonic plague and so on. But let's not go that far. 1918, there was the Spanish flu. It was a major pandemic that devastated the world. We learned a few lessons from that, and some of those lessons have come into play in the way we manage pandemics going forward. But let's go back to the most recent times. Many people, I don't know, some of you may not be aware of it, but Ebola epidemic, there was Ebola that has occurred periodically in Central Africa and that have migrated. The last epidemic of Ebola almost became a global crisis because it got to the United States as well. But there was rapid intervention from the President Obama administration to assist the countries where Ebola was a crisis in containing the Ebola epidemic. US infectious disease specialists were flown to Liberia, right? They worked in the fields. They helped to develop treatment options. There was a lot of global cooperation in stemming the pandemic in Liberia and other parts of West Africa where the pandemic was rising. It was a good recognition of the global cooperation that is needed to solve global health crisis. When this happened, if that rapid intervention did not take place, it will cross borders and it will become a problem in the United States and the rest of the world. HIV was a problem. When HIV was first identified, it was identified among a group of gay people. And because of the myopic mindset of the leadership at the time, looked at the gay population as a marginalized community to be ignored. And because it was ignored, it went mainstream. It is entirely possible that if there was more responsible and more responsive leadership that treated the gay community as a normal set of human beings, there would have been more attention and resources devoted to containing that crisis. And it may not have become the global problem that has lasted decades, right? So we always have these situations where marginalized communities are totally ignored and to the detriment of the larger community. You can make the same argument with the drug epidemic. When the drug crisis erupted in Black neighborhoods in Harlem, it was ignored. It was a Black problem until it became mainstream, and wars on drugs have been ineffective. So it's very important to recognize that the world has no borders anymore when it comes to disease transmission. Even when you go to the non-communicable diseases, you will see that even though the non-communicable diseases are not transmitted from individual to individual, they are lifestyle illnesses. As long as you continue to set up your fast food shops in developing countries of the world as a business to drive your economy, right? As long as you continue to market your tobacco products in the poorer countries while putting regulations in place to limit tobacco use in your country, you're going to drive the epidemic of non-communicable diseases like cardiovascular disease and cancer. And when you drive those, it will further deplete the resources of the poorer countries. And when you deplete their resources, then you will also continue to create problems that will lead to migration. So it is all intertwined. And so we have a lot of lessons to draw on from prior epidemics and crises. I don't think we're doing enough. I will just add one more thing that, the COVID pandemic is another situation where we haven't really put the lessons learned, never mind all the commitments, with COVAX and so on. Once the vaccines became available, there were a lot of pre-purchase agreements made by the richest countries of the world to hog up vaccines. And so you have countries that have excess supply of vaccines, and yet you have so many countries that cannot get access to vaccines, and that's inequitable. And that does not help the global community.
Okay, thank you very much. I think with that, we will wrap up this event. And thank you again, Dr. Madu, for a really brilliant conversation in global health. We hope this was enjoyable for everyone. And we look forward to seeing you at the next event, which you should find the link in the handbook. And again, thank you so much, Dr. Madu, for your time. We really enjoyed it.
Thank you for inviting me, and I hope you have a wonderful event.
Thank you.
Bye-bye.